I'd now like to introduce Dr. Ross Upshur, who will be facilitating an interactive mock REB meeting. Dr. Upshur is the Dalla Lana Chair in Clinical Public Health and Professor and Head of the Division of Clinical Public Health at the Dalla Lana School of Public Health. He is a professor in the Department of Family and Community Medicine at the University of Toronto, and he's also the Associate Director of the Collaborative Center for Climate, Health and Sustainable Care. Welcome to Dr. Upshur.
Thank you very much. It's a real great pleasure to be here today, and it's been such a stimulating and interesting meeting. And now to sort of steal from the pages of Monty Python's, now for something completely different. I am not going to talk at you for the next 45 minutes. In fact, you are going to be doing the bulk of the work. But I just want to make a quick observation. I'm going to try and say, I think it was Ben who said we needed to speak different languages. And so we're going to introduce the language of ethics into this. And it's kind of a warm-up and appetizer course for my friend and colleague, Jerome Singh, who's one of the leading experts in the world on ethics and adaptive trials. But I just wanted to make one observation. I couldn't help but notice in the last panel, for example, I think it was John who put up a picture of Austin Bradford Hill and the streptomycin RCT. I use that in a course I teach, and at the end of that analysis, Hill makes this really interesting observation that patients who had resistance to streptomycin fared much more poorly than those who had no resistance to streptomycin. So in the very, very first RCT ever published, antimicrobial resistance was flagged as an issue. In fact, it was flagged by Alexander Fleming himself in his Nobel laureate speech when he said the interesting thing about penicillin is you can't overdose on it, but you can actually underdose and create resistance. So we've known about antibiotic resistance since even before they were industrial synthesized. We've known about it since the first randomized trial. And the question is, why has that been still now seen as a problem? I also wanted to take a page out of Ben's book and put up a slide about what are the phenotypical characteristics of REB members, but I didn't have time to put that together. And just also, Francesca, if you're still on the line, I'm actually a snake bite survivor. I was bitten by a snake on a canoe trip in the Zambezi Valley about 25 years ago. Fortunately, I wasn't I didn't get envenomated because it was a rear back fang snake, and it only clipped me with its front fangs. And I was good friends with the chief herpetologist of Zimbabwe, who gave me his book on management of snake bites. So as I was sitting on the shore, about 20 hours paddle from anywhere, wondering whether I was going to die. So yes, let's improve the evidence base for snake bites. Okay. What we're going to do today, your table is going to constitute an REB. So if you're on a table by your own, I invite you to join a table so we at least have 4 or 5. And I think picking up earlier on the K versus N, we're going to have K number of REBs, and we'll have a little experiment in variation. So I want you to nominate a trial. There are protocols on your desk. This is going to show you how much fun, if you think statistics and adaptive platform trials is fun, ethics is fun too. So the interesting thing about this is it's challenging. So I want you to sort of frame all of the assumptions you have about what research ethics are and actually engage in this as an enjoyable activity of surfacing issues. So you're going to nominate a chair. And I mean, of course, this is a little bit forced. It's kind of an experiment. We'll see whether it works or not. Read the protocol. It will probably take you about 5 to 10 minutes. It's really clear and clearly written in about 4 pages. And then discuss what you think are the salient issues and be prepared to report back with at least 1 or 2. And then I'm just going to use my inner random generator to choose tables to solicit feedback from. So this gives you a chance to, 1, interact with your colleagues, 2, engage with a real protocol, and we'll see where this takes us. Sound good? Excellent. I really hope that you're, what's that? It's good. Okay, sorry. I have to take my glasses off to read this. And if I take them off, I can't see the room. Apologies for that. For those of you online, unfortunately, we have no capacity to make breakout rooms, and I'm very sorry about that. So you can create your own REB. You can create as many virtual people as you want, and I will call on some of the online participants, okay? And just to give you a little heads up, what are the typical things that you're going to look at? This is, is the research scientifically sound? Is the benefit outweigh the potential for harm? Is there an adequate process for informed consent and assent where applicable? Is there justice or fairness in selection of participants? And then you're noticed to focus on methodology, selection, and recruitment, informed consent, harms, benefits, and privacy and confidentiality. One last thing before I turn you to your tasks. All of you are capable of being on REBs. If you look at the Tri-Council policy statement on what are the minimal requirements for an REB, you need a person knowledgeable in ethics, not an expert in ethics, knowledgeable. You need a person knowledgeable in law. And you need a community member. So a community member is not someone with any scientific or methodological or disease-specific training. And interestingly, you need 2 experts in relevant research areas. So for those of you who are always complaining about research ethics boards, complaining about or finding fault with the methodology, remember that there's more scientists required on an REB than there are ethicists. In fact, there's no requirement that a research ethics expert be on an REB. So with that, I will stop. I will call you back in approximately 35 minutes. Or no, 25 minutes. No, 35. Okay, off you go. Okay, time to come back. So this is like a real life scenario because there are actually 8 REBs looking at a proposal. So you can all pretend that you're at different institutions. First, I'd like to thank Benita Hosseini for drawing up this draft. So a round of applause for her. And I know at tables there's selected ringers. So first off, people who are researchers, if you want to raise your hand. You're a PI, you're a researcher, good. Do we have any lawyers in the room? No legal expertise? People who have worked on or served on ethics review boards? So we've got a couple there. And recognizing intersectionality, anybody who is a REB member and a researcher? Okay, good. So I'm going to do this in an so I'm going to go to this table at the back. Who's the chair? Okay. Can you give me one issue that surfaced for you?
We noticed, oh, hi, thank you. We noticed equity and inclusion on the back, and then we wanted to consider why we would only recruit English-only speakers if the healthcare provider providing the CBT has cultural competencies for the ethnic groups being recruited. And then for patients who are receiving CBT, are you going to give them a psychiatry referral after if you notice that that's the most effective treatment arm? How are you going to kind of bridge that therapy?
Okay, great. Any other REB have that raised as an issue? This one, this one, this one. Oh, almost everybody. How about online? Did you raise that as an issue? So the first issue we surfaced was identified by all the boards. So much for interpretive variability. Okay, coming over to this side on that angle. Give me an issue that you identified.
So one thing we looked at was the informed consent section. We feel like there can be more information specified, specifically who's going to be conducting that consent process. They don't mention specifically an informed consent form. We think that could be more explicitly stated.
Okay. Is there any other REB that identified informed consent as an issue? That 2, 3, any other? Yep. Did our online board identify consent? Okay. So that's interesting. Consistency there. And as I said, this is an appetizer course because Professor Singh is going to tell you everything you need to know about informed consent and adaptive platform trials. So I'm just the warm-up act for his. How about the online ethics review board? Did they identify an issue?
Yes, someone said the dynamic nature of the trial, participants must be informed about, about the adaptive nature of the trial and how changes might affect their participation. They should understand that trial modifications could influence the treatment they receive or their participation in the trial. And another participant mentioned consent needs to be ongoing. Okay,
so consent, but did any of the REBs raise the issue of the particularities of adaptive design for consent? Hands up if you're REB. 1, 2, 3, 4, 5. So you guys didn't. So you're and you're the ringers in the room. No, just kidding. All right. For what did you identify an issue?
So maybe to go back about combining fibromyalgia and osteoarthritis, and then, for example, the intervention arm with NSAIDs, which is probably not going to affect fibromyalgia. So maybe to separate both diseases to different trials.
So you were questioning the very hypothesis itself, it seems.
I'm questioning about combining fibromyalgia and osteoarthritis in the same population.
Any other REB raise an issue around the appropriateness of the patient populations? We have one. Okay, so that's kind of a minoritarian concern, but not an inconsiderable one. So I'm going to come to the table with the ace statistician.
Well, can I cheat and follow up on some things other people did as well? Other people said? Is that allowed?
That's not called cheating. That's called adaptive ethical.
Adaptive. Okay, perfect. I fit right in here. So following on the equity piece, we also noticed some other things. They want to, work with marginalized populations, and yet they have some criteria that would require some justification around substance use disorder. I work in palliative care with James here, and you're looking at a chronic pain population. You said an age limit at 75 years. There's not really a justification for doing that, and we also brought up the English piece, so thank you for that. We also talked a little bit about, this will be our newer thing, around the control arm itself. And it was unclear what that would look like and what drug therapy was. We also talked about contamination risk with the control arm and the other three arms. And then for patients it seems like the patients who are in the control arm actually get followed in therapy for 24 weeks and everyone else has 12 weeks. And then it's like, you're on your own. It's unclear what happens to them after 12 weeks, whether or not rescue medications are allowed, things like that. And I'll stop momentarily, but we do have things about the statistical piece as well, because we had the benefit of having the statistician at our table. Happy to loop back to that.
Okay, we'll loop back to that. Did any of the other REBs raise similar issues around that? So I see one hand up, two hands up. And the online board, did they get in? Yep, okay, good. Now I'm going to go to the table with the research ethics ringer over there, the table of three.
I was just worried that somebody else was going to steal our ideas, that's all.
Oh, yeah.
Transparency. Probably our biggest concern for this study was no evidence of patient participation in the design. That this, we felt, was a paternalistic study, deciding who needed what when, and that there was no evidence of the patient population, whether it was a diverse population, non-diverse, English-speaking. There was no evidence of them in the design, which went with who's the principal investigator? And is it an MSK surgeon? Is it a psychotherapist? Who's the group here?
Who's driving?
Who's driving this bus? Yeah. And who's on the bus?
Those are tough words.
Yeah, there's a few more along that line, but somebody else may pick it up. So you can always come back first if we have more for that too.
Did any other REB find paternalism and the lack of inclusion of those with lived experience as a limitation in the study design? Truly minoritarian, but that doesn't mean, just because it's minoritarian doesn't mean it's salient. Okay, I think we can fit in the last two tables. How about this table here? Or have we covered all of your concerns? Or have we reached saturation yet?
Hi, so we have two maybe additional points. So the first one was looking at the intervention. So for treatment B, the exercise-based physical therapy, perhaps providing more specific details, especially if you have more sites included in your study. Each site could have their own rehabilitation strategy that may not be the same across the board. So what exactly does it involve? And also the type of exercise could not be useful for the population that they're looking at. So if you have someone being asked to run a marathon versus someone who sits and stands, that type of scoring system maybe would be required to see the strength that they've accumulated over time. And then something which is still new to us in our platform is not just asking for written consent, but maybe asking for verbal consent or getting consent over the telephone, having virtual visits as well, because some people cannot physically come to the hospital every time you want to follow up. So
Great.
those type
Yeah.
of things.
And I'm sure did other groups surface similar issues? Yeah, okay. Yeah, and I'm sure everybody wanted more details, but imagine if we decided to have you do a mock critique of a consent form. You would not be happy with me if I gave you the typical 20%. Last but not least, the final table.
Everything has been covered that we discussed.
Oh,
Yeah, unless I'm looking over the,
so we've reached saturation.
oh, hold on, I don't know if we have yet.
Yeah.
We're just wondering about in the statistical considerations. You know, I'm sure there's a lot more details that we're missing, of course, in this little summary, but you know, it would be good to look for a clinically meaningful difference in the pain in those participants.
Excellent. Anybody else talk about clinical meaning? There we go. All right, we're at time. Thank you so much. What a great exercise. Wasn't it fun? Yeah. Thank you. Cheers.